So we are live now.
Good. So, are we good to start now? Piyush sir, Anisha madam, can we start?
Yes, sir, we can start.
Okay, so that's
Ganesh, we can start. We can start.
thank you, sir. Thank you. So, very good evening to all. And this is the Nephrocon webinar, which we started 1 year ago. Every month, we conduct a webinar for one peculiar glomerular disease, and we try to integrate the understanding of nephrologists, nephropathologists, and try to bring things on one platform with one single aim on how to improve the patient management and treatments. So this evening we are discussing about anti-GBM disease, which has been a curious condition for so long time. We have multiple types of antibodies, multiple manifestations, and the treatments are also not very different from other glomerular diseases. But it is a curious entity when we integrate it with other conditions like double positive ANV, double positive lupus, so long and so forth. So let us begin our talk with Dr. Anisha talking about the pathological part of this. And I welcome Dr. Anisha Manocha for this. She is a nepropathologist from Max Super Specialty Hospital, New Delhi. And over to you, Dr. Anisha.
Thank you so much, sir. I'll share my screen.
Sure.
Are my slides visible?
Yeah, perfect.
So, good evening to everybody. My topic for today is anti GBM disease, and I'll start with what anti GBM disease is. It's nothing but a small vessel vasculitis which is caused by circulating anti GBM antibodies. And depending on whether there is kidney involvement or lung involvement, it includes three entities. First is good pasture syndrome, where both are involved. Second is anti GBM glomerulonephritis, where only the kidney is involved. And third is anti GBM pulmonary hemorrhage, where the lung is involved. To quickly recapitulate, crescentic glomerulonephritis is a term given when more than 50% of the glomeruli in a biopsy are showing crescents. And it's mainly of three varieties. First is anti GBM disease, second is immune complex mediated GN, and third is a posse immune ANCA associated GN. So now the difference between these three is mainly in terms of the age of the crescents and the underlying tuft. So anti-GBM disease is usually a single hit disease, which is why the crescents are usually always monomorphic, whereas in the other two, they are usually pleomorphic. If we look at the underlying tuft and we see necrotizing lesions or we see vasculitis in the vessels, that is usually a pointer towards an ANCA associated GN. Whereas if the tuft is proliferative in terms of endocapillary proliferation or mesangial hypercellularity, or there is GBM duplication, then we think of an immune complex mediated GN. And these immune complexes will come up on the IF as well as on the EM. Anti-GBM disease, of course, will have a peripheral, strong, linear positivity for IgG. Coming to the clinical presentation, this is a very uncommon disease, and the incidence is only about 1 or 2 per million population, and it accounts for 15% of all the crescentic glomerulonephritis. It has a bimodal age of presentation where the presentation can either be in the third decade or in the sixth to the seventh decade. And there are two major clinical presentations, either a pulmonary renal syndrome or more commonly what we see is an RPGN. There are many predisposing factors. It could be medications, it could be environmental factors like hydrocarbon use or cigarette smoking, or there could be genetic factors. So, what is the pathophysiology of this disease? Now, if we look at type 4 collagen is made up of 6 alpha chains. And out of that, alpha 3, alpha 4, and alpha 5, they form this protomer, and this is responsible for the stability of the glomerular basement membrane in the kidney. And the same protomer is also present in the alveolar basement membrane. So, whenever there is any sort of environmental insult or any genetic exposure, there is exposure of epitopes EA and EB, which are usually sequestered in the body. So, when the body comes in contact with these exposed epitopes, it develops autoantibodies, which are usually of the IgG3 and IgG1 type. And these autoantibodies are against the cryptic epitope of the non collagenous 1 domain of alpha 3 chain of type 4 collagen. So once these antibodies are produced, it results in a T cell activation and complement fixation, and all of this leads to damage of the glomerular basement membrane and crescent formation. So we'll discuss this case of a 60-year-old male who presented with acute kidney injury and fever since 7 to 8 days. So it's an acute history, and the creatinine was 11.3 with trace proteinuria. Now, all the glomeruli, there were about 8 glomeruli in the biopsy, all the glomeruli had the same picture. And if we look at this glomerulus, we can see this large destructive cellular crescent that is present. Here, the underlying tuft is not visible, and the Bowman's capsule also cannot be made out. The entire Bowman's capsule has been destroyed, and this crescent has replaced it, giving it a starburst appearance. So the underlying tuft is seen in this glomerulus. It looks more or less normal. There is no endocapillary mesangial proliferation. There is no GBM duplication. And here again, there is a large cellular crescent that is seen. If we look at the tubular interstitium, there is some amount of injury to the tubules and some amount of interstitial edema and inflammation that is seen. Here again is another glomerulus where again the underlying tuft is more or less normal with a large cellular crescent. This is the silver stain which is showing remnants of the Bowman's capsule which can be seen here, and over here the remaining Bowman's capsule has been destroyed by this crescent. Here we can see this multinucleate giant cell reaction to the crescent, and the inflammation here contains certain eosinophils. There are some cases where we can even see a periglomerular granulomatous reaction. And looking at the tubular interstitium, there is tubular injury and multiple red blood cell casts. When we saw the IF, the IgG showed a strong linear peripheral positivity. C3 showed about a 1 plus positivity, and kappa and lambda did not show any restriction. So at this point, this case looks like a very simple, straightforward case of anti-GBM. And the next day, the serology came out to be negative. So how does this happen that the serology is negative, but the IF has come positive? There are multiple reasons for that. First is, of course, it could be a false negative. If the ELISA is not using purified antigens or antibodies, that is one reason. And whenever the ELISA is negative and there is a strong suspicion, it's a good idea to go ahead with better, more sensitive techniques like Western blot. The second reason could be that the antibody production is either transient or the titers are very low and they have not been picked up. The third important reason is that the antibodies could be directed towards epitopes other than the EA or the EB epitope, or the antibodies could be against a different alpha chain, like an alpha 4 or a 5 chain. And lastly, of course, there is atypical anti-GBM disease, about which we will discuss further on. So, in this case, we did sign it out as an anti-GBM, and we suggested that the antibodies could be against epitopes other than the EA or EB, or against a different alpha chain. However, the testing was repeated using a line immunoassay, and there the anti-GBM antibodies came strongly positive. So the learning point in this case is that standard ELISA testing is positive in only about 87% of the cases, and 10 to 13% can still be negative. And again, whenever the suspicion is high, it's better to go ahead with more sensitive assays. So what is atypical anti-GBM disease here, and how does it compare with a typical anti-GBM? So, to put it very simply, an atypical anti-GBM disease is when the IF is positive and it's showing a linear, strong peripheral positivity, but the serology has come out to be negative. A typical anti-GBM is usually a rapidly progressive disease, whereas an atypical anti-GBM is relatively slower in progression. On light microscopy, also, it does not show a diffuse crescentic picture. The crescents are usually less than 50%, and the underlying tuft can show various patterns like endocapillary proliferation, mesangial proliferation, membranoproliferative pattern with or without a TMA. These are also less common. They have absent lung involvement and they usually have a better prognosis. So, this is a study by the Mayo group, and this is the largest study on atypical anti GBM disease, and it includes 20 cases. On light microscopy, they found various patterns, most common being endocapillary proliferation, followed by a mesangial proliferation. Other patterns include an MPGN pattern or an FSGS with mesangial hypercellularity. On IF, IgG was the most common immunoglobulin that was present in 17 out of 20 cases, and rare cases, one or two cases showed staining with IgM or IgA with only trace IgG. If we look at the IgG subclasses, the most common one was IgG1 and IgG2, whereas in a typical anti-GBM, IgG3 is usually the most common and followed by IgG1. Also, 50% of the cases showed monotypic staining with in the light chains, but on serology, only 3 out of all these 20 cases had light chain restriction. Coming to the differentials of a linear IgG staining on IF, the first is, of course, the anti-GBM disease, which is caused by the circulating anti-GBM antibodies, which go and get deposited here. The second is a monoclonal deposition disease or an MIDD, where there are physiochemical changes in the GBM and there is an affinity of these monotypic light chains which go and get deposited. So whenever there is a heavy chain or a heavy light chain deposition disease, there we can have a linear staining for IgG. But how we differentiate it is that in an MIDD, there will be staining in the entire tissue. The GBM will be positive, the TBMs will also have, sometimes the Bowman's capsule can also have. The third is a diabetic glomerulopathy, where again there will be a linear staining with IgG, but it will be a much duller staining and it will compare with the staining seen on albumin. Now, there are certain other diseases which can be associated with an anti-GBM disease. First, and the most common, is of course an ANCA-associated one, about which we will talk subsequently. Second is a membranous nephropathy. So, if we look at this IF picture, we can see a linear as well as this fine granular staining on the periphery over here. So, in such cases, IF interpretation becomes very critical. And third is an IgA nephropathy. So, this is another case of a 64-year-old male who presented with rapidly progressive renal failure with a creatinine of 8. The glomeruli showed cellular crescents. There was again a linear peripheral staining for IgG. And here, if we see IgA, there is a granular mesangial staining for IgA, and the capillary loops are not staining. Now, coming to a dual ANCA and anti-GBM positivity, approximately one-fourth to one-third of these cases usually have a dual positivity, and it is usually of the MPO ANCA type. They will clinically resemble anti-GBM disease at presentation. And the important thing to pick up in the biopsy is that the crescents will be of variable chronicity. So, an anti-GBM, like I said, is a one-hit disease, and all the crescents usually have. It's called temporal homogeneity, but whenever there is a dual positivity, we can see a temporal heterogeneity. These cases usually have a higher rate of relapse post transplant, but the prognosis is better than an anti GBM disease but worse than an post-immune. Coming to anti GBM disease post transplant, These per se usually rarely recur post transplant, but there is an important caveat. 3 to 5% of patients with Alport syndrome can present with anti GBM disease post transplant, and this is because of alloantibodies against the GBM antigens, which are lacking in an Alport patient. Such patients will have a clinical presentation similar to a new onset disease, and the serology will also be positive. Another important thing is that in these, the antibodies are directed against the alpha 5 chain, not the alpha 3 chain. And these usually have a higher risk of recurrence. So, anti GBM is usually an aggressive disease and it requires a rapid institution of immunosuppressive therapy. Again, it is a single hit disease, and the major predictors of outcome are the severity of renal injury, which is assessed by the number of crescents, and the serum creatinine. Thank you.
Thank you, Dr. Anisha. That was a really wonderful presentation. And at this point, I would like to welcome our esteemed panelists, Dr. Shishir Gang sir and Dr. Piyush Mathur sir. Dr. Piyush is from Jaipur and he's a senior consultant at Santokh J. Durbal Hospital at Jaipur. And Dr. Shishir Gang sir is from Nadiad. He's a very senior nephrologist. Good evening, sir. Um, so with this introduction, this is the basic pathology. And now we move on to the clinician's aspects. Now we move on to the nephrologist aspects and how we perceive this disease. Next slide, please. So this is the classical disease, like previously called as Gush-Pasha syndrome. Now we talk about anti-GBM disease, and this is what we see. The age distribution is extreme, very young, very old. We have beautiful looking immunofluorescence there. We have single organ involvement or dual organ involvement. Sometimes we get the antibodies positive in the serum. Sometimes we don't get them positive in the serum, and the manifestations are different. Like they may present as an RPRF, they may present as just hematuria, they may present as soro ESRDs, and they go on dialysis and they go on to develop ESRD quickly. And this is because we have a very high curiosity for this particular disease, and to diagnose this we need to have a very high index of suspicion. Next slide. So this is the phenotypic spectrum of anti-GBM disease. So we have double positivity where the two diseases coexist. Like for ANCA-associated vasculitis, we have something in it's a double positive for anti-GBM phenotype. Sometimes we get the antibodies which are not present in the circulation, but they are present in the biopsy. And there is a classical anti-GBM disease where we get both. So with this, we need to zero in on a particular clinical manifestation and ask for the lab reports like LIA, and you need to insist on when you have high suspicion of anti-GBM biopsy, and we get less antibodies in the circulation. Next. So when we talk of management, this disease management hinges on immunosuppression. We need to take out the invading antibodies with plasma exchange. We need to suppress the further formulation of these antibodies with either cyclophosphamide or steroids or rituximab. And now we have a new baby in our basket, like called as imlifidase. This imlifidase is an endopeptidase which cleaves the antibodies at the FC and FAB segment, but this is not a targeted antibody cleavage. So we may have the antibodies cleaved at multiple sites, some of which may be useful also. And last comes the kidney transplantation. During kidney transplantation, we expect a 50% of recurrence, and we may expect a de novo in almost, as Dr. Anisha rightly said, in almost 3 to 5% to almost 10% of patients with Alport disease. Next. And this was just one study I would like to project. This is about imlifidase, which is mostly talked about in ABO incompatible transplants. Now we are trying to extrapolate its abilities to cleave antibodies, IgG particularly, for other disease conditions. But we don't know much about this, and that is where I need to talk to our panelists hands on. Next slide, please. And this was the crux of all the guidelines. We talk about no maintenance therapy for IgM, anti-GBM disease as necessary, in contrast to other autoantibody mediated diseases. In refractory anti-GBM, we talk of rituximab, but most of the times the management is hinging on steroids and cyclophosphomides. So this is what most of people are like us are practicing and having varied outcomes and varied results. Next. So my first question to Piyush sir is that what is your experience in treating anti-GBM antibody disease, and how do you find rituximab useful?
Thank you, Girish. It was a very nice and brief illustration of a very rare entity, anti-GBM disease, not very commonly encountered. However, we do occasionally see these patients, but in my clinical practice, most of the patients, see, once I get your invitation, I recollected some of the patients. I think in last 3 years, I've seen 5 or 6 patients around. All of them require dialysis at presentation, and as far as I recollect, 3 out of these 5 or 6 patients are dialysis dependent. 2 or 3, I think they have lost for follow-up. So what I feel regarding this disease is that if the patient is coming to you with dialysis at presentation, most of these patients, they don't recover their kidney functions, and ultimately they become dialysis dependent only. However, I have not lost any patient due to anti-GBM disease. So I think that if we treat these patients well in time, then I think patient survival is okay with this disease. Literature also mentions that the patient survival is around 80 to 100% at 1 year. But if the patient is on dialysis and if oliguric, then I think these patients, they don't recover their kidney functions and they are dialysis dependent. Rituximab, however, I have not per se clinic used in all the patients except one patient where we thought that this patient might recover. But clinically, rituximab, I think, should be kept for those patients who are refractory to the initial treatment.
Absolutely.
So it is a good drug, I think, in terms that whatever studies have been done, rituximab has shown that the circulating anti-GBM levels antibody comes down significantly. They become undetectable. However, the recovery of kidney function is still a matter of debate. And some of the patients, they may recover the kidney functions, and some patients, those who are, again, like traditionally when we say, it is like those who are having high creatinine, oliguric, dialysis dependent, they usually don't recover even with rituximab also.
So, if someone is not responding to the treatment, so this is my question to Dr. Anisha, Dr. Piyush, and Dr. Shishir sir also. Do you recommend a redo biopsy? Do you do a repeat biopsy if somebody is not responding to the routine line of treatment like plasmapheresis or cyclophosphamide or giving a pulse? Dr. Shishir sir, what would you say?
Generally, as has been mentioned, that if the patient is dialysis dependent and the initial biopsy shows 100% or extensive crescents, then they are unlikely to recover. Generally, recovery happens only in those patients where a significant amount of normal glomuli are seen, or they are not dialysis dependent, but they are dialysis dependent with a lot of normal glomuli, then it is likely that they might have some degree of ATN associated, and these patients might recover. But if there is extensive crescents, 100% in majority of the glomuli, more than 80 or 90%, then a repeat biopsy would not be really useful because these patients are not going to recover. However, if you did a biopsy, patient is dialysis dependent, but there are a lot of normal looking glomuli, and we think that there might be a component of ATN, and you really have that difficult decision to make whether it has reached end stage or not. In that situation, one may consider doing a repeat biopsy. Otherwise, if there is 70, 80% or 90% crescents, which usually these patients, once they're dialysis dependent, would be having, then the recovery is unlikely.
So
Dr. Piyush, what would you say?
I agree with Shishir sir. See, why we want to do biopsy? The question comes: why do we want to do biopsy? What what are we going to achieve by doing the repeat biopsy? That is the question. So this question comes if we think that this kidney might recover by substituting any other immunosuppression like rituximab or so. Now, this question will come when you, in the initial biopsy, has shown that there is a significant glomeruli which are preserved. So, and the patient is not recovered despite of plasma and this, then I think that's the time when we can rebiopsy to see that whether there is any advancement in the chronicity, or still we can try the rituximab. Even after rituximab, if the patient is not recovering, then again it's a gray area where we would, for the prognostication to the patient, sometimes we need to do the biopsy to tell them that yes, this is the gone kidney and now we can't do anything, and let us prepare, go for transplant.
So, Dr. Anisha, do you expect anything new that would come up in a treatment resistant anti-GBM disease if someone does a redo biopsy? Do you expect something apart from the rise in the interstitial fibrosis?
Not really, sir. First of all, these are very rare cases. We generally see maybe one or two, or maybe maximum three, four in a year, not more than that. And most of the times, they will present with 100% crescents, and very rarely, or we have almost never seen a repeat biopsy for these cases, because they, like sir said, they always have a very bad prognosis. So we generally never get a repeat biopsy for these patients. They are generally taken up for transplant. In fact, when we see a biopsy where the crescents are so florid and almost 100% of them are involved, the first thought that comes to the mind is always an anti-GBM disease before we go and see the IF. So usually it's always 100% crescents. They're it's a very rare scenario when the crescents are less in number. So
So
repeat
now,
biopsies are very uncommon.
I agree. Very
perfect. So nuts, let us presume the patient in question has become dialysis dependent. And we are planning to do a transplant for this patient in, let's say, within 6 months or 8 months or 1 year. So would you like to continue immunosuppression during this time? Because the aim of that management would be to bring down anti-GBM antibodies and make them undetectable for at least 6 months. What would you say, Dr. Piyush?
Yeah, definitely the aim for if the patient is planned for kidney transplant, the aim is to make the antibodies undetectable. So that's the reason we have to continue the immunosuppression so that the antibodies becomes undetectable and we can go for kidney transplant safely after 6 months, because post-transplant recurrence of this disease is extremely rare if the antibodies are undetectable at the time of kidney transplant. So that's the reason if this disease is called as one and done disease. So once it is the disease is there, it's a done. So I think that that should be the goal.
Shishir sir, how will you go about this?
I completely agree with Piyush that generally will continue till the titers are negative, wait for a couple of months and then do the transplant. If they're not coming down for some reason, there's one odd patient we had, it was not coming down. In that situation, we gave Retox. But otherwise, most of the time, even with passage of time, in the past when we were not very aggressive with immunosuppression years ago, these antibodies would generally come down with time also. So just given time, most of them come down. Once they are negative, can transplant them safely.
Yes, sir.
So
Agree
what
with
will be time
sir.
frame for that? What time frame would you suggest for?
Generally, I would wait for 3 to 6 months because the disease is active. The patient is also settling down. Pulmonary thing, we are worried. If they are not involved in the pulmonary, then much safer to do it that way. But generally, I wait for 3 to 6 months to make sure that there is no evidence of any activity. Twice we would do the anti-GBM titers 4 weeks apart. And if twice done 4 weeks apart, both are negative, then we will go ahead and transplant.
Yes, sir.
Right,
So,
sir. That's
sir, your
perfect.
point is very well taken. This point of giving rituximab, this is another indication for giving rituximab if the titers are not coming down even after giving a conventional immunosuppression, then rituximab is considered to be a good drug in bringing down the titers waiting for transplant.
That's perfect. Simaji, next slide, please. So just we'll move on to one case. I'll just read it out for you, sir. A 56-year-old male patient with anuria and abdominal discomfort. Creatinine on arrival is 9. There are no lung involvements, and the patient initiated on hemodialysis. Kidney biopsy showed crescentic glomerulonephritis, which is a mix of cellular and fibrocellular. There are linear deposits, IgG, and serum anti-IgG, IgM antibodies, and PR3 ANCA are positive. So, what would be your preferred line of management for this patient? This is a dual positivity with very little or minimum lung involvement.
Just as Dr. Anisha rightly and very beautifully presented, that generally the dual positives have actually better prognosis than the single positives. But important here again is to see the biopsy again. If there are 100% crescents, extensive disease, then the likelihood of recovery is very poor. However, if there are that, as they said, that if there is a telescopic like thing, meaning there are some which are dead, some which are alive, in that situation, one may consider giving them plasmapheresis and immunosuppression with the fond hope that over next 4 to 12 weeks, there will be some recovery or not. If there is no recovery at 4 weeks and the anti-GBM titer have become negative, NCA serology is getting negative, kidneys on the sonography are looking fired up, the RIs are more than 0.8, then the real question comes whether to persist with more immunosuppression or not. Because as you understand in nephrology, it's always very challenging not to do something because you're all tempted to do. But even at the same time,
Yes.
there is the risk of sufficient immunosuppression. So in these patients, I generally, to be very honest, these dual positives, but if there is extensive anti-GBM and 100% crescents, they don't recover. So at 4 weeks, generally, I would do everything again, look at it, and then maybe abandon the treatment. However, if there is a urine output coming, if there is RIs are good, if it was only partial involvement in the initial biopsy and the ANCA serologies are very bad, maybe they are the small group which might recover partially. If they show partial recovery, then we would continue the treatment. Important to note in these cases, if they do improve, then they would require long treatment because there is a risk of recurrence, especially with ANCA positive diseases, unlike anti-GBM disease. So we would continue immunosuppression initially with endoxan and then switch them over to MMF or azathioprine. In the past, we were using a lot of azathioprine after 3 months, but nowadays MMF is the preferred one after 3 months. And then continue over a period of next year or two, see what was the best baseline creatinine they achieved. And after 2 years, maybe gradually take it off and then see how things go. And then this role of rituximab, again, it might be considered, but as we have very limited experience in anti-GBM, mostly we try to use cyclophosphamide because I feel that that's a more, I think, more powerful immunosuppression compared to Ritux in every situation of grave diseases that we have seen. Even the bad membranous or a bad vasculitis, cyclophosphamide does better. Again, here the role of oral in anti-GBM is much more than IV. At least the data with oral is much more than IV. So we tend to use oral initially if the patient is not tolerating or if there are other reasons, or then elderly where we think the infection may be a problem. Then we do something like a urolupus or something. But generally, we begin with oral and see how things go.
So, if there is a solitary anti-GBM disease, there may not be any need for maintenance immunosuppression. But when it becomes dual positivity, you would prefer maintenance immunosuppression, which may last for 12 to say 24 months.
Yes, generally we would
So,
see after that how things go.
so do we check the antibodies again after 12 months or 24 months?
Anti-GBM should come down. Generally, by 3 to 6 months, they would come down. NCA titers, do they come down? But titer correlation in NCA is not as perfect as in anti-GBM. So sometimes even when the clinically the disease is quiescent, meaning the urine examination is normal, proteinuria are not there, the creatinine has hit some sort of a baseline, which may not necessarily be normal. But if activity in the urine is not there, clinically patient extra renal things are not there, and that because this PR sometimes can get extra renal manifestations are not there, then we would not chase the titers exactly for the NCA. But we generally tend to do it But keep that in mind. But I would again intensify the immunosuppression only if there's a clinical evidence of a activity in the urine or a rise in the creatinine. Just based on the titers, we will not intensify the immunosuppression or consider it as a relapse. So that's a little difference from what we think for the anti-GBM and titers in ELCA.
Right, sir. Thank you so much. So this was about the native kidneys, but when we talk about transplanted kidneys, that too particularly when the recipient has an Alports, maybe a call for A5 call. So do you check these de novo anti-GBM antibodies as a protocol, or you wait till there is a graft dysfunction? And what would be your recommendation?
Generally, in Alports, as we mentioned earlier in the presentation, that there is a risk, but it's very, very low. It is 3% in most of the literature, and but in many large cities, it's less than 2% or so. So generally, we don't check the titers only if there is an active urine sediment, if there's a hematuria, or if there's a rise in the creatinine. We would keep a very low threshold to biopsy these patients because checking does not really help because how frequent and how long do you check, and sometimes this can come much later to it. Secondly, because this is to most of it is because of these X-linked recessive, where the mutation is in the alpha 5 chain compared to what the titers that you get is in alpha 3. So most of the antibodies detect alpha 3. Though at times, even in alpha 5, you get this alpha 3 positivity in Alports. That's what is mentioned. So one checking is not usually recommended, and we don't check ourselves in our department. But if there is any active sediment or rise in creatinine, we'll have a low threshold to biopsy these patients. Fortunately, though we have transplanted a lot of Alports, touch wood, we have not seen any case of a recurrence in at least in the limited experience that we have.
Right, sir. Thank you so much. Next slide, please. So, we have seen the popular protocols or the time-tested protocols, and they are mainly studied in native kidneys. So, my question to both the panelists is, are there any multiple protocols for treating post-transplant de novo anti-GBM disease? And how would you select them? Like, what should be the most suitable protocol for that particular patient? Because whatever protocols we are using for the de novo anti-GBM disease, it comes from the knowledge from the native kidney diseases and all those trials conducted for native kidneys, and we couldn't find a particular trial for anti-GBM disease. So Dr. Shishir, will start from you. What is your take on this issue?
Again, as I have no personal experience in this situation, but my reading goes, I would select what is recommended in the native disease. Stop the anti-proliferate, either it is MMF or Azoran, will stop that and change that to cyclophosphamide and give cyclophosphamide for a period of about 12 weeks once they tolerate, usually 2 milligram per kg. But if there's a severe renal dysfunction, and maybe reduce a bit of it, and then after 3 months, see if the patient recovers, then switch them back to the other anti-proliferatives. Role of rituximab has been discussed, and there are occasional case reports and all. Again, no personal experience, but if patient is not suitable for cyclophosphamide, or if is not responding and still we think that there might be some chance of recovery, one could consider giving Ritux in that situation also. But I'm not.
Any role for plasma
Yeah,
exchange?
we would do plasmapheresis for this. I'm sorry, we would do plasmapheresis for all these patients, and usually give it for 2 weeks and see how things go. Because most of the times, daily for 2 weeks and see if they have any recovery in that or not.
Dr. Piyush, how would you differ, or do you concur?
Yeah. Nobody can differ with Shishir sir, Girish. And so the thing is that I think that post-transplant anti-GBM anti-GBM itself in native kidney is a very rare entity. And post-transplant, I have not seen any patient having anti-GBM antibodies. What I learned from the literature is that the treatment is same as that of native kidney, including pulse steroids and plasmapheresis and cyclophosphamide, oral cyclophosphamide. Again, sir has already mentioned that we need to withhold the antimetabolites and continue the cyclophosphamide and come back to again MMF or azathioprine once the treatment is over. So I think no major difference in treating the de novo anti-GBM disease post-transplant when we compare to the anti-GBM in the native kidneys. So it is almost the same.
Right. So, what I could gather from the discussion is that we don't have to differ in our management for post-transplant anti-GBM disease and a native kid anti-GBM disease. So, we are most likely ending up treating both in a similar way.
Right.
And the aim is to bring down the titers. Aim is to improve the kidney function and bring down the activity in the urinary sediments. I think with that we go to the next slide. So this says new year. We will be beginning a new chapter of Nephrocon in the next year also. But this has been a long journey, and we discussed all these kind of things on a monthly basis. And the message that goes is that we need to talk to each other when it comes to glomerular diseases. The nephropathologist and the nephrologist, they need to interact. And uh, as I can collect from this, I would definitely continue with these endeavors. I have just one last slide remaining. Can you show me the last slide? So, okay. So this is for all the three panelists. So now we have gathered most of the information about the anti-GBM disease from the transplanted kidney and the native kidneys. And let us divide it into two, like atypical and typical. In typical, we are having the sub classifications of IgG as IgG 1, 3, and 4. When we talk about the atypical, the IgG 3 goes away. And when we talk about the severity of disease, the typical one looks to be a little more severe. The atypical looks little less severe. So my question to first to Dr. Anisha is, how often do you recommend to do subtyping or subphenotyping of the IgG, which is involved in causing the pathogenesis? Like, would you recommend to do it on a routine basis? Because if we look at the distinction here, we can see the classical has a poor outcome, the better outcomes is atypical. So are we looking at subclassifying or subphenotyping the the IgG antibodies, which are actually the culprit for development of the disease? Till now we discussed about the histopathology, the serum titers, the renal function, but do you need to sub phenotype these IgGs? What is your take on it?
So if we have subtyping, it will definitely help. But whether it is absolutely necessary, no, I don't think so. Because if we have a light microscopy picture of diffuse crescents, IgG is positive, the serology is positive, it is a typical anti-GBM. Now, whether that is IgG 1 or 3 or 4, it can definitely add to the report, but I don't know if it is really going to change the management or not. I don't think that's going to happen. Similarly, with an atypical anti-GBM, again, the light microscopy and the serology should be concurrent. Light microscopy and IF should be concurrent. Serology is negative. We have some amount of proliferation. We can still go ahead and call it an atypical anti-GBM. If we get again an IgG2 or an IgG4 or an IgG1 and we don't get an IgG3, it might just reinforce the diagnosis. It might just help in confirming that diagnosis. But other than that, management and prognosis wise, I don't think it really changes much.
Piyush sir, what would you say about this? Subclassifying the IgGs. Could it be the next level, or could it be just academic exercise? I
Sure,
think you are
muted.
muted, sir.
I think, Girish, it will be more of an academic exercise. And see, any intervention, any investigation which we want should be combined with intervention. If we are doing any investigation or anything we are adding to that, then there must be a rationale whether this is going to change the management or is it of any academic interest. So I agree with Anisha that when already there is a 100% crescents linear deposits and the diagnosis is clear, subclassifying it, whether it is going to change the management, yes or no, I don't think so it's going to change the management. So yes, for academic interest, we can always further subclassify by doing the subtyping of these antibodies.
Shishir sir, what would you say?
I agree in general with all of that. Only one patient where I had a patient who came very early of 2.5 creatinine, a lady, and she was found to have typical anti-GBM. We treated her. She was all right. Creatinine came down to normal. Then a year and a half later, she came again with nephrotic range proteinuria. We did a biopsy again. It showed membranous. So I think in patients who have any proteinuria, we generally with anti-GBM, of course, when they come end stage, usually that's not a problem. Come with renal dialysis dependent renal failure. But if they come early on, and which is very unusual. Very few patients we see them early in the when they are less than like 3 creatinine or so. And if they have significant proteinuria, I think that is one small subset where maybe going more deeper into it, whether it is only anti-GBM or associated with something else, would be of an interest. But if they come end stage with extensive crescents and everything, then maybe that may not really need to. That's a small one single case where I felt that whether we could have diagnosed something different earlier, a dual positive or something, which we missed, and then later on it became manifest. But that's only one case.
Because when we were talking about the immunosuppression, we recommended to give immunosuppression on a maintenance base for a dual positivity rather than a single positivity. So does that make sense to check all these phenotypes on a repeated basis and find out a recurrence?
And very few patients actually improve. So it's only rare patient that we get which come early. If they come early, I mean, then it's all makes sense because then you really want to make sure that are there any dual positive associations. Elderly patient, you want to do if there any restrictions are there. There are associated with IgG4 also. But if you find any some other clue has to be there to chase that further. I'm sure if there is a proteinuria, if there is uh, nephrotic range proteinuria or something where we don't find in these cases, then maybe dual positivity could be considered.
So I have one question in the chat box. Purva is asking, is there a particular time frame after which serology would be positive, and how much should we rely on serology? This is for recurrence.
So recurrence of anti-GBM or because generally anti-GBM doesn't recur. So, but if
No,
if as mentioned by Dr.
this is
Anisha,
for the de novo thing what we see in post transplant.
okay, post-transplant. Post-transplant, generally, if only you should buy the serology, how frequently can you do it is not possible. It's not reliable. I would only go by the urine examination and the creatinine rise because it is
Yes.
very uncommon even in the literature. So why unnecessarily spend the money and energy? And even if you find that
Yes.
positive, and if there is no rise in the creatinine, the urine is normal, we are not going to treat those patients differently. So
Absolutely.
unless they have a crescentic-like picture, we are not going to treat it differently. So I would not do a serial anti-GBM titers. I would just wait for the event and
Yes,
pick it up
absolutely.
early.
If the allograft is working well, I think most of us will be happy with that. We won't be subjecting for so many investigations, because if something comes positive with a functioning allograft, we don't know what to do with it. So that is a fixture in I think transplant immunology. And with that, I think we are coming. If there are no questions, Simaji, in the chat box, we can uh,
Yes, so there are no further
ask for
questions.
any questions. Anybody? Any? So that was a wonderful interaction, and I think there are so many insights about the anti-GBM disease. So we should take this forward, and this will be continued as a continued program, continued education. And thank you so much, everyone, and Dr. Anisha, Dr. Shishir sir, Piyush sir, for joining us for tonight. So Simaji, can you just conclude?
We would also like to thank you for getting us all together
Yes.
and a very good, nice interaction
Good,
today.
Girish, and thanks, Shishir sir. It's always something, some learning from you always.
Yes, yes.
Uh, so thanks for giving me this.
Because this point was not in the KDIGO guideline about the maintenance immunosuppression for a dual positivity. This is something new I learned today. Thank
Thank
you
you so
so
much.
much.
Thank you so
Thank
much. Thank you for having me.
Thank you, sir. Good night, everyone. Bye.
Thank you.